Bonjour.
Bonjour Yves, heureux.
C'est pas votre tête, c'est normal.
Oui, c'est normal, j'ai enlevé la vidéo. Alors, je fais un petit test, Yves, actuellement. Nous sommes en direct sur YouTube.
D'accord.
Voilà, donc on va tester ça si ça vous va, ou alors je l'arrête et on se le garde pour une autre fois. Il y a deux possibilités, c'est de faire du live. Donc le webinaire est retransmis en direct sur YouTube et il pourrait être aussi retransmis en direct sur Facebook.
D'accord.
Voilà, donc là aujourd'hui j'ai choisi YouTube. C'est
Ouais,
sur ma chaîne propre, Antoine Vidal Indivox.
d'accord.
Normalement, il ne devrait pas y avoir grand monde parce que c'est une chaîne qui est plutôt perso
Ouais,
et c'est plutôt un test. Mais on pourrait tout à fait envisager pour les prochains webinaires de faire un peu de pub sur ce live
d'accord.
YouTube et passer votre virtual classroom sur la chaîne Indivox.
Ah ouais, pas de problème.
Voilà.
Vous
Donc
voyez mon
on est
écran là, c'est
parti.
bon?
Oui, je vois votre écran. Très bien. Il n'est pas en plein écran, mais vous avez réussi à récupérer votre cas clinique?
Oui, oui, en fait, je pense que c'est le fait c'est la copie qui a dû mettre un petit peu un petit peu d'émotion.
D'accord, bon, ben ça va. On
Voilà.
est, on est pas mal. Bah, vous me dites quand vous êtes prêt.
Ouais. Alors attendez, parce que c'est vrai que ça a commencé par ça, cette image, c'est un peu con. Sauf si je mets ça, et parce que c'est vrai que je mets d'emblée le cas clinique. Donc, alors attends, je peux faire une copie. Tac.
Sinon, je peux vous faire aussi une slide, hein, si vous voulez,
Euh,
vite fait.
ah non, celle-là, elle n'est pas terrible, celle-là. Ok. Euh, ouais. Attends, parce que je voulais faire ça. Je voulais balancer. Attends, je vais arrêter de partager l'écran, peut-être. Je voulais faire ça, mais le problème, c'est que les couleurs sont pas terribles.
Il est 18h01.
Ouais. Euh, attends, on peut faire tout en noir. Hop. Ça, on peut le mettre dans du vert, comme ça. Voilà. Ça, on peut le mettre vraiment en noir. Voilà. Et normalement, pour ça, on met tout ça en noir. Tac. Par ici. Par là. Hop. Voilà. Ok. Hop. Ça, le trait en noir. La tête un peu mieux comme ça. Alors attends, je partage.
Mhm.
J'y suis. Et j'y suis.
Parfait. Allez, c'est parti.
Okay. So you speak or I speak first?
You speak first, as usual. That's
Okay.
not problem.
So welcome everybody, and happy and honored to welcome you in my classroom about the Haglund Syndromes and the chronic insertional Achilles tendinopathy. So to start and to have some clinical, technical aspect, could you use your tools to tell us that we hear me and you see my my screen. So you could we could move on if the answer are more or less positive. So you can use your chats or questions, and probably because I have not a good view on that, Antoine, so maybe you could help me to tell me if it's okay, if I can start the session, and if it's good for everybody.
Yes, it's okay. Turta is confirming that that sound is good, and I think that everyone can hear us.
Yeah.
So
Okay.
if you have some problem, don't hesitate to put your questions on the chat box. This is your space, and if you have some technical problems, also I can help you. So
Okay.
don't hesitate to put your comments.
I don't know if my video is working. My camera, my
Yes, your camera is working.
my
No
camera is
problem.
working. Okay. So so the topic today is about the Haglund syndromes and the chronic insertional Achilles tendinopathy. So it's a mixed. So my first things was to introduce for a clinical case, and then I will develop the different aspects of my view on that topic. So it's a story of a male of 41 years old. He's a marathon man, and he has a posterior heel pain, and he has a lot of shoe impingement, and he is unable to run long distance at the moment. So he's very frustrated because he did a lot of marathon, and at the moment he is unable to do this. So he has a posterior heel pain, and this is a clinical presentation with the Achilles insertion very painful. The severe skull test was positive, and the dorsiflexion was at 0 degree, so that means totally neutral. And there is a cavus foot with no varus. And this guy has a lot of medical treatment, but at the moment when he went to visit me at the outpatient clinic, he was totally in failure of the medical treatment. That means orthotics or insole was working a little at the beginning, but at the end it was not working. He did a lot of stretching, and there was a special stretching program, and the shock wave was totally also unusual for him. So regarding the imaging, he has a posterior cavus foot with a pitch angle over 18 degree because it was a 25 degree. We could speak about the length of the calcaneus, but I will explain what is the length of the calcaneus, and the ratio was under 2.5, and there is no calcification at the insertion, even there is a beginning of 1. So, but most of the time in this case, there is not a huge insertional tendinopathy. So, and the MRI show a bone impingement. We have here a lot of fluid here, and you have edema into the bone, in the contact of the Achilles tendon. There is also retrocalcaneal bursitis, and the Achilles distal end tears was under 30%, and it was assessed by horizontal slice on this area, and you can measure the thickness of the Achilles, or the distal end of the Achilles tendon. So my question, and then I will move to the presentation, but you could think about this. The fixed option was first to move on and to continue the conservative treatment, to propose a calcaneoplasty, plus an Achilles tendon distal end release, to do a calcaneoplasty plus a Zadek osteotomy, a calcaneoplasty plus a Zadek plus an FHL augmentation, or to make a choice of another option. So I will stop this presentation, and so you can think about this, and maybe you could send a vote. And so I repeat the question: conservative treatment, calcaneoplasty plus distal end release of the Achilles tendon, calcaneoplasty plus a Zadek osteotomy, calcaneoplasty plus a Zadek osteotomy plus an FHL augmentation, or other option. So maybe you could answer with this and send your question, your reply, and we will see at the end of the presentation if you are still in the same feeling, or if I change your mind a little bit, or not at all. So it could be a big debate for me, but we could also discuss on the option I choose, depending on what option you choose also yourself. So I start sharing my screen because I'm going to change my presentation. And
yeah. Sorry to disturb you. I will start now. Now we have passed the clinical case. I will start the recording.
Okay. So so I share and so what is the topic today? The topic is about the Haglund syndrome and more or less a chronic insertional Achilles tendinopathy. So we have to go back some backgrounds. There is different presentation. The first one is so-called Haglund disease. It's an impingement between the back of the shoe and the superior margin of the calcaneus, and because the superolateral calcaneus bone is too prominent. And more or less, it's a presentation for young patients under 30 years old, and more or less often women, and it's aggravated and increased by the shoe wearing. And there is skin irritation, local erythema, and focal swelling. The second presentation is insertional Achilles tendinopathy. That means tendinosis. The patients are older, between 40 to 60. They are less athletic, but sometimes they are also veteran sports, so there is both population. And sometimes the patient could be overweighted, and they're like sedentary people. We can find a bone spur, sometimes an intratendinous ossification, and sometimes, when the case is long-term, a partial tear at the insertion of the Achilles tendon. And you can see here, the calcification is moving from there to there. That means the calcification is going up due to the disinsertion of the Achilles tendon distal end. So, but the problem is that the distinction between those two presentations is not very clear between Haglund and insertional tendinopathy. When you go back to the literature, sure, Haglund is young people. There is not very reproducible X-rays measurement, and we will speak about later on. And it's more subjective morphological assessment. And sometimes it's associated with bursitis and tendinopathy. So that means the first presentation is not only without bursitis and tendinopathy, because sometimes there is. Another things to think about is the posterior cavus foot, what I call the posterior cavus foot. And it's one of the most frequent radiological morphological factor. That means there is an increase of the pitch angle. That means the pitch of the calcaneus is over 18 degrees. And you have here a clear example with the young patient, Haglund syndrome, but very big problems between the tendon and the bone. And here, in this case, the cavus foot with 25 degrees of pitch angle, and also problem with the Achilles tendon. So bone problem, but also Achilles problem, and it's not always easy to make the difference. So I prefer, in this moment, when I say I am not alone, and there is consensus starting in the literature and in the foot community to speak of impingement pathology. And this impingement pathology could be indirectly performed due to an overuse, because you have a varus of the hind foot, because you have a cavus of the hind foot, and also because you have a gastroc contraction. And this impingement could be also directly performed because you have a prominence, and Haglund syndrome is a part of this, and you can see here, because you have an overlength of your calcaneus, and I will explain what is an overlength of the calcaneus, and also because you have posterior spurs, because the posterior spurs increase the thickness of the posterior aspect of the calcaneus, and increase also by itself the Achilles tendon distal end. So it's caused by the impingement, but also it causes also an impingement. It's the same like with the hallux valgus. When the head is moving medially, it's a cause of impingement, but also there is an exostosis, and the exostosis becomes also a cause of impingement. So it's a circular vicious. And most of the time, and it's the reason why I wanted to make this classroom, because most of the time it's both. And you have to deal with bone and soft tissue disorders in the meantime, and leading to different clinical presentation. And you have retrocalcaneal bursitis, retroachilles bursitis, insertional osteophyte, insertional Achilles tendinopathy, with or without a gastroc retraction. So how to deal with this on a practical point of view, because it's my philosophy, because I am a surgeon maybe, but when you're a doctor, you need to have practical point of view, according for sure with the literature, but at the end you have to make a summary and a take-home message of what you have to do. You have to assess before the treatment. You need an interview of your patient about job, history and previous treatments, very important. What about the shoe wearing? What about the sport activity, and especially in this case, running and trail and sport or long distance? That means risk of overuse of this area. You have to make a physical examination, and one of the things very important is the foot morphotype, either cavus, either the foot is pronated. How about the Achilles tendon, the body, but also the insertion? And in this case, it's more the insertion, which is very painful than the body of the Achilles tendon. And you have also to assess perfectly the contraction of the gastroc. Some very brief reminder. The severe skills test is now very trendy, and in my practice, when I have examination of every problem of foot or ankle, I do the severe skull test. And you see here, in knee extended, there is a lack of dorsiflexion. And when you flex the knee, you improve the dorsiflex. And that means there is a gastrocnemius contraction. At the opposite, when you do not change anything, that means whatever the position of your knee, flexed or extended, your ankle remain in equinus position. And that means it's a gastrocsoleus contraction. It's the whole triceps, which is too much contracted. So it's not a debate today, but it could be because you can see that post-traumatic aspect, or more or less in neurological problems. The third thing is very important is a weight-bearing lateral foot X-ray. And on that weight-bearing lateral foot X-ray, you will assess the shape of the calcaneus. And there is a lot of traditional measurements. If you go through the literature, you have the Fowler and Phillips angle, you have the Hennegan-Pavlov, that means the parallel pitch, the parallel line. You have the Rich, and the Rich pitch angle, and which is the angulation of the orientation of the calcaneus. And you have also combined measurement, which is Chauveau and Viet. But if you go through the literature, all those measurements are few specificity, except maybe one is the Rich angle. So I published 2 years ago a paper, and I describe a new measurement, which is the X on Y ratio, the tournée measurement. So XY ratio, and it's a ratio. And when you have this, so here is the overlength, the total length of your calcaneus, and here is the length of your grid tuberosity. And when this ratio is under 2.5, that means you have an overlength of the calcaneus. So I invite you to read this paper, because I took a population of patients with a case control group, and I compare the two groups. One group was painful on the heel, and the other group was no pain on the heel. And most of the people of the painful group has an overlength of the calcaneus. So I described this new measurement, and it was reproducible and very specific instead of the other measurement. So my gold standard at the moment regarding non-clinical evaluation, regarding imaging assessment, is on this X-ray on weight bearing, the length of the calcaneus and the reach angle, that means the pitch angle, that means the inclination of the calcaneus. So I use those two measurements on the X-ray AP view in weight bearing. And the other very important assessment is MRI, because I want to assess the condition of the Achilles tendon on the distal end of the Achilles tendon. And you can see here different presentation. And every time there is a lot of inflammation with a retrocalcaneus bursitis, retroachillus bursitis. There is tears in the calcaneus, very degenerative changings on the Achilles itself. So you have different things. And you can see here, all those patients have a cavus foot. And you have also associated sometimes fasciitis also, and you can see here and here also. So at the end, you have different treatment. For me, the first treatment, the first line treatment is non-surgical treatment. Even I am a surgeon. When you are a foot and ankle surgeon, you are not exclusively surgeon. You are also general practitioner for the foot. And so the rest and shoe wearing is very important, and you have to choose carefully how will the posterior aspect of your shoe if you want to decrease the impingement. Non-steroidal pills could be also always, but it's not a long-term treatment. It's not possible. Orthotics, and to correct cavus foot, and to correct and to elevate the posterior aspect of your foot to decrease the impingement. Rehabilitation is very important. Probably more stretching than the Stanish. I don't know if everybody knows Stanish. Stanish is a eccentric and concentric and exercise, and it's to treat the non-insertional Achilles tendinopathy. But in the case of insertional tendinopathy, you have to make stretching, but not concentric in the same, because there is a high risk to damage more the distal end of the Achilles tendon. The shock wave, there is no consensus in the literature. There is no evidence-based medicine on that, and the same for the PRP. But they could be, maybe, if we have more big series, more patient data. Probably this could be also. And so I recommend if you have a problem to deal with the surgery, maybe to do those techniques. Even this at the moment, it's not totally recommended because there is no evidence-based medicine on that. But the one thing that I am completely sure that you have to avoid steroidal injection, because if you inject steroidal injection here, there is a high risk you provoke the rupture, the disinsertion of the tendon, and the weakness of the distal end of your tendon. And see, you can see the different. I use that one also because when the patient have no time to do this, they can do this in the morning and in the evening, and at these 2 times of the day, they can perform stretching. But it's better to, if the patient have time to do this, and you can also to ask him to use inverse shoes at home to increase the dorsiflex and to struggle against the retraction of your muscle. But be careful not to increase impingement between the tendon and the bone. So you have to deal in between, because this area is very sensible for the patient. When there is a failure of the conservative treatment, you need surgical treatment. And probably it's a big difference between the Achilles tendinopathy of the body of the Achilles and the insertion, because most of the time, maybe 80% of the Achilles tendinopathy on the body are on medical treatment, and only 20% required surgery. And for the insertion of tendinopathy, probably in the reverse. That means the majority of insertional tendinopathy and Haglund syndrome will require at the moment a surgical treatment. So what is the decision making supported by? So it's a summary of my previous slide. First, I need, after the clinical evaluation for sure, I need a weight-bearing AP view, X-ray, and I use 2 measurements. My measurement, the length of the ratio X under Y, and the pitch angle of rush. And the MRI, because I want to assess perfectly what about the insertional tendinous lesions, location, extension, if there are not a retrocalcaneal bursitis, and what about also the condition of the cancellous bone on the calcaneal greater tuberosity. And after that, the procedure involving the calcaneus will be effective. We have to keep in mind that you need to remove the posterior superior aspect, that means the Haglund deformity, the genuine Haglund deformity. You have to change probably the pitch angle because you have a cave foot. You have probably to reduce the length because you could have an overlength of your calcaneus. And that means you can also to try to decrease the gastroc retraction, and on request, if there is an associated varus, but probably it's a more complicated case, you have to also correct the varus in the meantime because it's possible. And so you have to play with isolated or combined bone procedure combined to soft tissue techniques regarding the Achilles tendon condition. So it's very important to have the shape of the calcaneus, to propose the patient a bone procedure, but also the MRI to discuss if it's interesting or not to do something on the distal end of the Achilles tendon. So this is my plan, my surgical plan. It's most of the time a surgery à la carte, I will say in France. So you can use calcaneoplasty, and we will develop later on. You can use a calcaneal osteotomy. You can use osteophyte resection if there are, and if we need to do this. You could also gastrocnemius fascia lengthening. I'm sorry, I inversed in my presentation. And also you have to deal with distal end augmentation. So that was my first part. And then if you agree, I will go in the different technical aspect, surgical technical aspect. Do you want I move on, or do you want to start discussion, or what do you want? I move on, and we will discuss at the end. Okay. Antoine, there is some.
No, Yves, I didn't see any questions on the chat box, so
okay.
you can go on.
Right. So the second topic is the bone procedure, and So it will be a more technical, more surgical topic. And the background is the same, pitch angle and the length, and the MRI. Even the MRI is more adapted to the soft tissue, but it's very important also to know if there is a very big change, a very big injuries in the distal hand, to propose the bone procedure isolated or combined, okay? So the calcaneoplasty is a posterior superior resection, and you can see here at the beginning, and I remark it's a 25 pitch angle, so it's a very big cavus foot. But the option in this case was to do posterior superior resection isolated. And you can see here the change between this and that due to the calcaneoplasty. I recommend to avoid extensive debridement at the Achilles insertion. It's the same that you have to avoid extensive debridement when you do a rotator cuff because there is a high risk of secondary rupture. And this procedure can be combined, isolated or combined to other bone or soft tissue procedure. So it's a part of the technique. It could be an isolated technique, but it could be also combined to other bone or soft tissue procedure. So I have a short movie. The patient is in lateral position, and my the approach is a little more extensive than I use, because in this case I have combined both techniques. So you can see here my retractor, and I can make a stop of the image. I'm sorry. Yeah. So I put my retractor here, and to protect my Achilles tendon in the back here, and here I am at the apex between the insertion of the Achilles tendon and the bone. So in this part here, you see my hand, okay? In the part here, you have the insertion of your Achilles tendon, right? So it's a lateral approach. Probably when we do an isolated procedure, probably the approach is a little less extended than in this case, because in this case, at the same time, I did the calcaneoplasty and the Zadek osteotomy. I will show you what. So we move on, okay? So I remove the Kager inflammation because on the MRI there is a big one, and you can see here there is a very huge synovitis, and I draw the corner I want to remove, and I test here, and I show you here. You can see here the big impingement there were. Sorry, the big impingement there were between the Achilles tendon here and the bone, and so we are going to remove this to decrease this impingement. So I use a saw. I start the saw on the lateral aspect, but I don't go and I finished with a chisel because I want to protect the medial soft tissue, okay? And you can see here some detachment. Yeah, you can see here the piece of bone I remove. And then here is the distal end of the Achilles tendon. And now when I do the flexion, the dorsiflexion, you see there is a space, a remaining space. That means there is no more impingement. This was an open procedure, but you can use also minimal invasive surgery or endoscopy, and that was described by the usual guy to describe that means Van Dyke, and it was published in more recently in a clinical foot and ankle clinic. The patient is in supine and position of the foot internally rotated. Sometimes you could also use a prone position. There is two portal, and you use usually the knee arthroscopy device. An image intensifier is intraoperatively is mandatory to assess exactly where you are. And I have no experience personally, and so it's thanks to my two colleagues from EFAS and ESCA who provide me this slide, and you can see here the amount of resection you can perform with a burr, a rotative burr, and to decrease the impingement between the bone and the tendon, What are the results of this calcaneoplasty? The open procedure, because there is a long-term experience with the open procedure, and there is a lot of publication. And at this moment, the results were immediately very good. But there is recurrence and residual complaints at mid or long-term follow-up. And the minimal invasive surgery is more recent, and there is less wound complication for sure in comparison to open, and the seems to have better results. Sorry for the mistakes. There is some better results at midterm than to compare to the open procedure. But whatever the technique by open or by minimal invasive surgery approach, you have to keep in mind that pre-op intratendinous injury is a negative predictive factor for the final outcome. That means the MRI is mandatory. In my plan it was, because if you have any intratendinous injury of the tendon, probably the result of the isolated calcaneoplasty will not be good at long-term follow-up. And you have also to keep in mind that the shape and the orientation of the calcaneus remains unchanged because you do this. This cavus foot is always a cavus foot. This cavus foot is always a cavus foot. So you do not change. You do not change the shape. You do not change the pitch angle. You do not change the length of the calcaneus. So could be an explanation of the long-term not very good results of this isolated calcaneoplasty. So, and an example, and because at the moment when there is because the patients have an Haglund syndrome or something like that, there is the techniques is immediately sorry for that. The technique is immediately to do a resection of Haglund. And this example of a female, 43 years old, at the pre-op MRI there is intratendinous Achilles lesion, but never mind, the surgeon did a resection, and with a posterior superior calcaneus resection plus a tendon release, which is not totally recommended, and the MRI at 5 months showed a complete Achilles insertional necrosis and the complete disinsertion. And you can see here, this lady has a very huge, very, very good dorsiflexion, but there is a very, very good dorsiflexion because there is no more insertion of the tendon. And it was a pure calcaneoplasty, but the calcaneoplasty probably was not really indicated in this case because there were a very severe damage in the tendon itself, and because probably there is a debridement, an over debridement. That means at the end of the debridement, the tendon was more or less detached, and the result is very poor. The second surgical technique for that is for bone procedure is the calcaneal osteotomy. Go back to the history because it's interesting. It was described by Vadek in 1939 as a grid tuberosity rotational osteotomy. He performed 3 cases with an osteosuture, and the result was more or less not too bad, but at this period, the scientific report was not at the same level that now. Keck and Kelly, 30 years after, described a more effective techniques, stabilized by impection staple, but probably there is a malposition of the osteotomy, and there is a lot of subtalar impingement, Achilles impingement, and aponeurosis irritation. So the evolution was not too bad, but not exactly what now is the new Zadek osteotomy. Denis and Martin, in some years after, make a modification because they think about to advance the grid tuberosity. So my idea also, but it was not demonstrated, my idea to decrease the length probably of the calcaneus, because probably in those calcaneus the length was too big, too high. So they decided to make a grid tuberosity advancement without any rotational effect, and there is less aponeurosis irritation of overtensioning, because the position of the osteotomy was anteriorly to the insertion of the aponeurosis. The series was bigger with staples to stabilize. And now the new trend in Zadek osteotomy, and I published the first technical things in some years ago. It's a dorsal closing wedge osteotomy with the vertex of the osteotomy is plantar, and with the cortex is more or less preserved. And it's always distal to the, it's always proximal, distal, to the aponeurosis insertion to avoid any problems with the aponeurosis itself. And so the vertex could be posterior, anterior, you can see here. So the vertex, that means is the apex here. And you can also to be more proximal. Personally, I prefer these things. And so that means you can change a little bit the angulation of the correction, because it's a rotational correction. So what is the exact, how the Zadek osteotomy works? It's reduced the overall calcaneus length, and you can see here on this small animation, and you can see here after the resection, you have the length A and the length B, and B is under A. That means you reduce the length, and that means also if you calculate the ratio, I will show you after, you increase the ratio. You decrease the impingement with the Achilles tendon. Why? If you give a look here in orange is the orientation of the Achilles tendon, and in blue here is the tangent to the posterior aspect of the calcaneus, and you measure an angle. And when you do the calcaneus osteotomy, you increase this angle without any calcaneoplasty. You can do an additional calcaneoplasty, but without calcaneoplasty, you increase the place and you decrease the impingement with the Achilles tendon and the bone. And this angulation is over the first one. You decrease also the level arm for the Achilles tendon. And this is very important, because you have to think about that when you think about retraction of your gastroc. You decrease the level arm of your Achilles tendon, and I will show you how, and you decrease the pitch angle, and this is the reason why you decrease the level arm, because you move to such an horizontalization of your calcaneus. Look at this, and because it's a rotational correction, that means this point is elevating, and because this point is elevating, this point also is elevating. That means when you recalculate your pitch angle, you change your pitch angle, and this pitch angle is the yellow one is under the blue one. So because of that, because you elevate the insertion of the Achilles tendon, it's the same thing if you have elongate the Achilles tendon itself without any surgical procedure on the Achilles tendon itself. So it's interesting to, and I am developing at the moment a study, very simple one. I measure all my Zadek preoperatively, and in postoperatively, I just measure the dorsiflex in extension of knee. I have a frame with I use my phone, and I use the measurement of the phone, and you can calculate the angulation. And I fixed on the boat, and I put the foot of the patient in the boat, and I did this 2 measurements, 2 repetitive, so I have an interclass and an intra-class evaluation, and it will work. And at the moment, most of the patient improve their dorsiflexion postoperatively without any surgical procedure on the tendon or the gastroc itself, and without also a lack of strength performance. So it's very interesting, and it just because I did a Zadek osteotomy. You can also perform an additional calcaneoplasty, depending on if you have a lot of problems, and it's sure that you increase again the space for your calcaneus. But by the Zadek itself, you improve your angulation, and you can improve more your angulation with an additional calcaneoplasty. So it's a small video. The patient's in the lateral position, prone, if you decide to combine soft tissue procedure. So I could discuss with some surgeon who are listening, I could discuss how to manage in the same time a Zadek osteotomy and a surgical soft tissue procedure. So the same approach. So I go straight to the bone. I don't make any dissection. And it's like for a calcaneus fracture, no dissection of the subcutaneous is the best way to have no skin problems and no soft tissue problems. This is what I do. I remove this, and you can see I maintain this intact, and this point is elevating, and because of that, you make some retraction, and you struggle the retraction of the Achilles tendon. So I do my Zadek osteotomy. What I do, I can stop first. I do my first. I try to have a more or less a perpendicular cut for the first one, perpendicular to the pitch angle, and the second one is oblique, and because of that you change the orientation of your pitch, and also you change the length of your calcaneus. So my first cut is posterior, proximal to the insertion of the CFL and the calcaneofibular ligament, not to damage it. This is perpendicular to the pitch, and the second cut, that means you have a wedge. The second cut is oblique, and depending on the amount of resection I want, but at the moment it's true that there is no real planification, and probably could be interesting if I move on this. It could be interesting to calculate the amount of bone you have to remove depending on the length of your, because now we have a ratio on the length and also on the pitch angle, and probably we could play with these two measurements to make a planification of the amount of bone to remove. But it's a study in progress. So so we remove this, and you have to be careful. Most of the time the medial soft tissue are sticked to the bone, so you have to detach it and you have to remove the periost. So you remove your corner, and which is interesting that you have to stress a little bit the plantar aspect, and at the end, and you can stress just, not to cut but just to stress, and then it's an automatic close. So it's self-stable. So you maintain the osteotomy by two provisional pins, and then I use a plate. You can use whatever. I prefer plate because I don't like to put a screw in the back of the calcaneus, and I use locking end compression. So the two screws here are to make compression, and you can see here. Look at the bone here, and you see here there is a very strong closure, and because it's a double one, and you see here all the bone out, and then I finished by a locking screw. You can do that also with a minimal invasive surgery, supine position. Use also again an image intensifier. I have no more experience than that. And also there is Anthony Pereira, they published on this. Probably you have to remove a lot of bone here, and you have to pay attention also that could be you can crack here. So you have to be careful, but probably not so easy than it could appear. But it could be also an option to do this in a new trend way to perform surgery. So the literature is really poor on that. The first was published in the American Journal of Surgery with 3 cases, 3 women, and another one, it was Keck and Kelly, and I will speak about this, and 2 very good results and 2 fair. So it was not exactly 18 cases of osteotomy, but 18 cases of posterior heel pain. And another, Martin, and what I show you, and it was not so bad, but there is a 3 nerve neuroma, so pay attention to that in the approach. And the last publication was performed by Carlos Menu from Lille, and most of the patients were of the cavus foot, and the results was very good and good at long-term follow-up, about 4 years and 3 years, and fair in 5 and poor in 2. My personal experience, and I have submitted for publication so at the moment, because I wanted to have a more long-term follow-up. And at the moment, it was about 6 years medium follow-up. That means that patient was at 10 years, some was more recent. A cohort of 21 patients, and with Jadek osteotomy, and I screen all that and to do the paper, and the average alpha score was very good, and the VISA score also regarding the pain, and the Tegner, which means a return to sport, was very excellent, and there were no pain at follow-up, and the MRI criteria, that means the change from one aspect to the other aspect of the distal end of the Achilles tendon was very good due to the Zadek osteotomy. And you can see an example here. It was elective for surgery because the ratio was sorry, under 2.5, and the angulation was over 18, and after surgery the ratio was over 2.5. That means I reduced the length of the calcaneus and without any additional surgery. So that was my second talk on the bone procedure. So my third and last talk, and after we could move to the clinical case again, my last talk will be on soft tissue procedure. So there is 2 options, or we discuss now, or we discuss at the end, or maybe at the end after the clinical case solution. So we could have an overview on that before. Okay? Are you agree with that, Antoine?
Yes, if we don't have any question on the chat box.
Okay. So, that's right. So, again, the backgrounds for me for the decision making, for the surgical decision making, is weight bearing, lateral view to measure 2 things, the length and the inclination, and an MRI to assess what are the conditions of the Achilles tendon. Always the same. So the opportunity to make a soft tissue procedure is regarding the condition due to the clinical examination, to X-rays and so on. So you can add in the panel of your procedure, in the portfolio of your procedure, you can use gastrocnemius fascia lengthening. It was published by Marino Delmi from Switzerland, and renewed at the date by Genchos in the Foot and Ankle International. most of the time in this case, because you need to be stronger than the proximal, I prefer striar procedure. That means it's a medial gastrocnemic fascia, and we can also compare it to the surgery promoted by Baruch. That means the medial gastrocnemius proximal. That means at the posterior aspect of the knee, but probably this way is less powerful for that problem, and probably it could be enough for metatarsalgia, but probably not enough for insertional Achilles tendinopathy. So I recommend, if you have to do a gastrofascial lengthening, to do by the striar procedure. For sure, the indication is the contracture, and the goal is to start like this and to finish like that. That means with knee extended, you improve the dorsiflexion of your ankle, because with the severe skilled test, you are here in a knee extended, but you are obliged, preoperatively, I speak, you are obliged to flex the knee if you want to obtain an improvement, a gain of dorsiflex. Here, after the surgical procedure, you have this gain of dorsiflex in knee extended, because you did the release and the elongation of the striar procedure. But I probably will publish in some months, when it will be approved, that when you do a Zadek osteotomy, even you have a retraction of your gastroc, because you have carefully assessed clinically your patient preoperatively, you are not obliged, if you decided to make a Zadek, you are not obliged to do this additional procedure, because the Zadek osteotomy automatically improve the dorsiflexion, because the Zadek osteotomy automatically works as an elongation of your gastroc. It's very interesting. The second soft tissue procedure is when you have very big posterior osteophyte, very big spurs, and when those spurs are a part of the problem. That means those spurs are so big that they are also a source of pain themselves. And because regarding the MRI, there is a very strong degenerative aspect of the distal end of the calcaneus. So you are obliged to remove these osteophytes. You are obliged to remove the distal end of your Achilles tendon, because if you don't do that, there is a high risk to have always a painful heel, even you did Zadek osteotomy or whatever. But because you do that, and if you want to properly debride and remove the osteophyte, you are more or less obliged to detach the tendon. So you are obliged to make a reattachment, because if you don't do so, whatever the way you will use to do this reattachment, if you don't do so, there is a high risk of recurrent pain, and most of the time, a high risk of total detachment of your distal end of your calcaneus. So there is a different way. The first described was by using anchor. It was the technique of Saxena and McGarvey published. And you can see here, you open like a digastric. You open the calcaneus, the Achilles tendon. You don't totally detach it, but more or less, yes. And then you fix. But probably when you do this, there is a risk to leave some part of spur, because the spur is not on one plan, it's a ring of spur, and the spur is running from here to here. It's a ring, a posterior ring of spur. So if you want to remove it, probably you are obliged to detach all the tendon. And the question is, are those two anchors enough to reattach strong, as strong as possible to reattach the tendon. So it's a reason why I moved to another technique, and I can show you the results of that. So digastric Achilles tendon approach. In the meantime, it was a choice of the surgeon. Even there is in this case a case, but it's not my case, and it's a case because I have to reoperate those patients. And in this case, you digastric Achilles approach, osteophyte, and you do in the meantime the calcaneoplasty because you're on the vision. And at the end, you reattach with anchors, like in this case, and it's probably at the moment not so fashionable, but also more effective and more efficient. I use a speed bridge system, and this is very, very strong. So I will show you a short video on that. So the patient is in prone position. And what I explained at the beginning, you can do in the same time the Zadek osteotomy and that. Because when your patient is in prone position, you can externally rotate the hip, and you have your lateral aspect of your calcaneus ready to do a Zadek osteotomy. And then when you finish your Zadek osteotomy, and if you have to do this, you can put your patient you can just internal rotate it, and you do not change the position of your patient, and you make a separate approach, a medial approach, and you can do that. So you open your Achilles tendon in the middle, you detach it, and I recommend to detach totally to have the best overview on the ring of the spur. You do the same on the other aspect, and you can see here, you remove again your Geiger because there is inflammation, and you can see all the ring of spur. So I remove the ring of spur. It's a reason why the entire detachment, in my opinion, is necessary. And then you combine this to a calcaneoplasty. Okay. Now you think about, you be sure that there is no, so you think about of the reattachment, and it's the same procedure like for a rotator cuff with a double rank of anchor, but the anchor in this case are screw, and you use a fiber tape. So your first screw is to reinsert a fiber tape. So you reinsert your fiber tape. Okay. You do the same on the other aspect. You see it's very bulky. And so you go into your, so I use a Reverdin because in France we have not access to the needle immediately on the fiber tape. So I use this, which is a trick when you work in France. And you do another hole to insert a double another anchor. Then you cross your two fiber tape. So you mimic the tension, and personally I put my foot in neutral position. I don't want to over tighten. Okay. And then I reconstruct my posterior. And you see here, I previously removed, I did a calcaneoplasty, and I did a Zadek osteotomy, and I finished by the resection of the spur. the last topic is about augmentation plasties. There is, on the moment, two kind of. The first was described by my friend Jean-Luc Bess in Lyon. He used the same technique like for ACL reconstruction, and he used the knee extensor system. And the second one, the FHL transfer, and you can understand why, because the FHL is very close to the Achilles tendon. And it was published and described some years ago, and probably Hansen was one of those. We did a lot of works on that. The indication to do this is because you have a very severe insertional tendinitis and with a partial detachment over 20 or 30%. That means when you have a very severe impingement, even you remove, even you did the calcaneoplasty, even you did your Zadek osteotomy, the injuries, the tears on the tendon are so severe that they will not recover properly after time. So in the meantime, do both, because if you don't do so, probably it's a source of failure of your Zadek osteotomy and so on, because you leave a very big suffering in the distal end of the Achilles tendon. So it works, it's to improve the blood supply and the healing of your Achilles tendon, because thanks to the osteotomy or thanks to the calcaneoplasty, you remove the impingement, but you improve and you increase the speed of recovering of your distal end, because you bring to this distal end of the tendon blood supply with the transfer or with the bone tendon graft. So some words, because those slides are from Jean-Luc. The patient in the lateral decubitus, for the same reason we explained, and there is a very, very severe damage here, and because this man or lady, I don't remember, has a lot of injection, corticoid injection. And in the meantime, you do a short anterior knee approach to harvest the plasty and a piece of tendon and a piece of patellar bones. And then you insert the bone into the bone. So you use the patellar part to insert into the bone, and you put a screw or a normal screw or an interference screw, whatever. And then you gap, you split the gap, and you jump the gap with the Achilles tendon, with the extensor tendon. He published his results with a very nice result, and that was three kind of patient he had in this series after so big release. And so I do not recommend the strong release. I don't recommend any release, just the release of the Kager after a repetitive corticosteroid injection, or as is in this case, the primary indication, because it was a long-term evolution of the impingement. And he has very good score also at 4 years midterm follow-up. But it is a simple, solid bone fixation. No extensive skin dissection is recommended, but in my opinion, there is a knee surgery in the meantime. So probably it could be debated, because at the moment, there is the gold standard is probably the FHL transfer. The FHL transfer is the gold standard of any repair of the Achilles tendon. You can use a long harvesting. That means you are obliged to free your FHL at the plantar aspect of the foot, because if you need a long transplant, there is, you remember, connection between the FHL and FDL at the plantar aspect of the foot, and if you don't release that, you are not able to weigh out the entire part of the FHL. The second option is to use a short harvesting. That means you interrupt the road of your tendon at the entrance of the calcaneus canal tarsi here, and so you are not obliged to go to the plantar aspect. You can do that under arthroscopy, and Louis make arthroscopy everywhere. And if you know him and if you follow his publication, he performed arthroscopy everywhere in the foot, and he published the first description on that. You can use a calcaneal tunnel because you have a long transplant, and so you can make a long and probably more useful when you have a chronic rupture on the body of the tendon, more than in disinsertion, because in the disinsertion the problem is very close to the calcaneus, and in this case is far from the calcaneus. So probably the calcaneal transverse tunnel is more or less associated with long harvesting. Okay. And when you have short harvesting, you can use fixation with anchor and better with interference screw. And I will show you the technique. And recent publication, I am sorry I have not put the reference here. I think there is two. There is no side effect for sports. That means because you pick up the FHL to do a reconstruction of your distal end of the Achilles tendon, there is no side effects for sports, even for athletes. That means, yes, they decrease the flexion of your RP, but the effect on your practice, on the level of practice, is not. So it was not a pity for those sportsmen and sportswomen to have this technique. So the surgical decision making. So I think I have another one. I am going to stop here and I will show you the technique. Okay. So maybe you think about that. Any question? No? Any question from the audience?
No question on the chat box, Yves. Perhaps I will open all the microphones at the end of the presentation.
Yeah, but now I finished this. Okay. I am so the last technique is that one. So I share my screen. Okay, it's good for you. So the FHL transfer. So the same approach, a medial approach. So you are immediately on the medial aspect of your Achilles tendon, and you can see here, you have the aponeurosis, posterior aponeurosis of the FHL, and you open this, and you see the belly of the FHL, okay? When you follow it, you have the tendon, so you have to manipulate it carefully, because it's not a so strong tendon. And the reason is not to bring a strong tendon, the reason is to bring the belly, that means blood supply. So because I decided to make a short approach and short harvesting at the entrance of the sinus tarsi, of the canal tarsi here, then I secure it by the fiber loop system, but you are not obliged to do this. I like to do this because it's easy it's easier, and then you can size it. And so you have different tools to size, because the size of your tendon means the size of your drill. You can see here. So I come back to show you something interesting. So you see here the medial aspect of my Zadek osteotomy. So I did a Zadek osteotomy first, without any change in the position of my patient. Just I play with the rotation of the hip, okay? Then I size and I use the drill adapted to the size of my tendon, right? I put a pin from the posterior aspect and at the immediately anterior to the footprint of the insertion of the Achilles tendon. That means that my Achilles tendon is inserted here, and I put my tendon just immediately anterior to the proximal to the distal to the Achilles insertion, right? So I finish drilling. Then I use a special passer wire, the same you can use for everything. And in the same time, I put my foot in neutral position. I don't want to over tighten. It's not necessary. And then when I have the good tension, I use an interference screw to lock it. I check if there is no problem. And very important for me, I secure the distal end of, I secure the belly, that means the blood supply, and the tendon to the Achilles tendon, because this area of the Achilles tendon suffered. But I don't do any debridement on that. I don't want to weaken it, okay? I just bring blood supply to improve the healing. Right. So I come back to my last, to the end of my last talk. Now it's okay. So it's such a conclusion. The surgical decision making, 2 steps. The first, posterior heel pain is a mixed syndrome involving bone and distal end of the Achilles tendon. So you have to deal with an Haglund and more or less insertional tendinopathy. It depends. So you have to deal with the rush angle and the calcaneal length first. If the rush angle, that means the pitch angle, and if the calcaneus length is normal, you can perform an isolated calcaneoplasty. It's very some selective people, because in my practice, it's very unusual to have that, but we could have. If the pitch angle, that means if there is a cavus foot, if there is an overlength of your calcaneus because the ratio is under 2.5, that means if those measurements are pathologic, you need a Zadek osteotomy, because if you don't do so, your calcaneoplasty will not be able to do anything for the pitch angle of the calcaneus length. The second step of thinking is either any calcification. What about the insertion Achilles conditions? That means what are the knowledge from the MRI? If there is a lot of calcification, you need to resect them because they can provide an additional impingement, and we will not be able only with your Zadek osteotomy to change the position exactly. You could change the position of your calcification, but most of the time, if they are big, those calcification will remain a cause of impingement. So you have to remove them, and I recommend to use a speed bridge or another system, but a very strong system to be sure that the Achilles tendon will be stick again to the distal to the calcaneus grid tuberosity. If there is very severe damage on your insertion of the Achilles tendon, I recommend to augment by a FHL augmentation. And all those techniques, even the soft tissue procedure, could be combined together with a surgery à la carte. So if I go back to my clinical case, and if I found the right file, So my question, I remind you, my question was, so I'm going to close this to be sure there is no problem with that. So this is the right file. So it's not working. It says, yeah. So the question after the presentation of the case was, what about a conservative treatment? Is the calcaneoplasty indicated in this case? And I remind you, it was a cavus foot and with an overlength of the calcaneus. Is it necessary to distal and release the Achilles tendon in addition to the calcaneoplasty? Do you recommend calcaneoplasty plus ZX, or do you recommend to use an FHL augmentation? And I remind you that the change in the distal end of the Achilles tendon was very few. So my choice in this case was to do a calcaneoplasty, to add a ZX osteotomy, but no FHL augmentation. And you can see here, it is a patient I show you in my previous presentation. The patient moved from one aspect to another aspect. I changed the shape of the calcaneus, and I was not obliged to do an FHL augmentation because the tendon was at this level of, was not at the high level of trouble, because I do my calcaneoplasty and ZX osteotomy at the right time. Probably this guy seen maybe 5 years or 6 years after could be obliged to do an additional procedure or FHL augmentation. So Haglund syndrome are multifactorials. There is bone and tendon disorder mixed most of the time. The calcaneus shape evaluation is mandatory, and you have to assess two things: pitch angle and length. Don't do any other measurement, because it was mentioned in the literature that they were not reproducible except those. The bone procedure are calcaneoplasty and DADEC. Sometimes you are obliged to do FHL augmentation, and sometimes disinsertion of the calcaneus, of the tendon, to remove calcification. That's the end of my talk. Thank you very much for your attention. And so now I can share with you what you want.
So first of all, I will open all the microphones if you want to ask some questions. But there is already a question on the chat box from Mr. Siddiqui. When do you combine ZX with FHL augmentation, and how do you select?
So I think it was my final algorithm. Probably the question was during the presentation. Yes. It was my algorithm. When I have two examinations, two non-clinical examination. First is the weight-bearing X-ray, and then I check if there is a pitch angle increase, if there is an overlength of the calcaneus, and in this case I say yes for VADEC. And when the distal end of the insertion of the Achilles tendon is very injured, that means when there is tears and damage over 20% of the thickness of the calcaneus, I combine with an FHL transfer. In this case, my surgical technique is I put the patient on the prone position. With an external rotation, I can perform easily, even I can use also a flexion of the knee, and I can perform easily the ZADEC, and then I put again my lower limb in normal position, that means in prone position, and then by a medial approach, I perform the FHL transfer. Could you please close your microphone because there is a yes phone babies so on.
Sorry.
No worries.
I don't know if you can hear me.
Yeah, where are you?
I am in Paris.
Yeah, but do you have your, who are you, Pierre Julien?
No, sorry, I'm Antoine.
Antoine. So it's possible to but yeah.
I can't, sorry for my English, but I can't activate the video. So
Okay. No worries. I listen
sorry.
to your question.
Yes, it was at the beginning, you showed us open tracheoplasty and the arthroscopic or mini-invasive. Sorry. Yeah. And there was a very important difference from my advice of the importance of resection.
Yeah.
And I did some procedure, and usually my resection are, I think, closest to the arthroscopic resection. I mean, I usually do maybe too small resection. And you think it's important to extend it or not? Because I was afraid of resection a lot, and yeah, to expose the tendon to complication.
So I think I can go back to the to my presentation. It will be easier to show you. Partager l'écran. Okay, that one. Partager. Okay. So I think if you see the screen?
Yes.
Yeah. I think the problem is not to remove too much. The problem is to remove till the insertion of the Achilles tendon. Okay. Because if you remove there is a remaining impingement. Okay.
Okay.
But is to go till there and not to stay more proximal, but not to stay too distal. Because if you are too distal, there is a high risk to weak the insertion of your tendon. The amount of resection is more or less when you have a very important impingement. That means the real Haglund deformity. And the real Haglund deformity is unusual. I think there is a statistic represents less than 20% of the so-called Haglund syndrome. That means the deformity of the bone, very prominent on the posterior aspect, as a deformity of the calcaneus itself, is about 20%. But if you want to do this, why not? But keep in mind that whatever you did in open procedure or in endoscopic or minimal invasive surgery procedure, you don't change the shape of your calcaneus. So if you have an overlength of your calcaneus, you don't change it. If you have a cavus foot, you don't change that. So I think it's a good thing if you have no problem of cavus foot and if you have no problem of overlength. In this case, probably the calcaneoplasty will work. And it was my first experience. When I start my experience with this technique, I learned to perform calcaneoplasty. Okay, and so I did. Zadek for me Haglund calcaneoplasty. And at the moment, a part of my patients went back at some years follow-up with pain again. And so I say, okay, why? I give a look at that. I look at the publication of some colleagues. at the moment, there is also the publication from Carlos Menou from Lille, and it was, I say, okay, yes, there is not only the prominence, yeah, there is also the cavus foot, and so I start with my experience with Zadek, and when working on Zadek, I say, okay, why Zadek is working? Why is working? Because it's such a calcaneoplasty, but without calcaneoplasty, but I just move forward the grid tuberosity, yes, but I change also the slope, I change the pitch angle, so I decrease the overlength, and so on and so on. And so it was a lot of justification of why Zadek is working when you have a cavus foot, when you have an overlength, and why the isolated calcaneoplasty on the long term doesn't work.
Yes, yes. I perfectly understood that, and I found it very interesting. But
Yeah.
my question was just about arthroscopical
Yeah.
calcaneoplasty, and I found maybe with the arthroscopic. So in the case you showed, it seemed to be maybe not enough, but
yeah, maybe. But I think but which is important is to be at the apex of the insertion between the tendon and the bone, to be sure that you remove all the bone in this area, and so also to check what was possible with open procedure. I show you, I check intraoperatively that the amount was enough to leave a space, an additional space, even I am in dorsiflexion, okay?
Okay.
But you can do the same during arthroscopy, and you can also check under arthroscopy. You can move and make dorsiflexion, and if you have a very quick when you start dorsiflexion, if you have a very quick contact between the bone and the tendon, that means you have not removed enough. That will be my advice on that, because it's the same advice I will do for open procedure, because it's only the way to perform surgery we change, okay? But the rules are the same, to be at the insertion, at the cross, at the aspect of the insertion and the bone, and to remove enough bone to avoid any quick contact between early contact between the bone and the tendon. And that you can check it in open procedure, and I think you can check it also in a minimal invasive surgery or endoscopy procedure.
Yes, and that's why it's better to have X-ray control during.
And so you can and you can confirm that by an X-ray control for sure.
Okay, thank you.
No worries.
If we have a question from Turta B, what are the most important recovery aspects of the tendon after Zadek and or calcaneoplasty?
Okay, so
first question.
It's a good question. After my regimen, after the surgery, there is such a cast, and and the weight bearing is depending of what I did on the. If I did a Zadek osteotomy, I think there is no weight bearing for 1 month, and because my frame is very strong, I use early weight bearing at 1 month, but protected by a boot. So maybe more or less there is 6 weeks with a boot. Okay. Even there is additional procedure like FHL transfer or disinsertion, reinsertion. After that, all my patients have special insoles, wedge insoles, and to maintain the heel up and to decrease the tension on the insertion of the tendon. Because you have to keep in mind that more or less you treat a kind of insertional tendinopathy, and the return to sports could be different because if you have no MRI signs at all of tears in the tendon, I think the return to field could be at maybe 4 months. But if you have tears in your tendon. That means if you have a severe insertional tendinopathy due to the shape of your calcaneus, and because of that you were obliged to do a bone procedure associated to a soft tissue procedure, in this case, for me, I maintain the patient out of the field, like for sports, like for foot, for hiking, and that's basketball and so on, 6 months. Because it's a tendinopathy of your Achilles, and most of the time the tendinopathy has to be protected from sports with traction, about 6 months. How do you assess amount of bone to remove in ZADEC? So for CDK, it's a good question, and the question was how to do you assess the amount of bone? At the moment I have no assessment, but probably because I am lazy. That means I probably it could be a good thing to do a study on that. That means you have an overlength of your calcaneus. What I said during my presentation, you have an overlength of your calcaneus. You have a pitch angle increase. You have both. So you know that the length is when your ratio move from under 2.5 to over 2.5. You know that the good slope is under 20 degree. So you want to do this, and probably it could be interesting. You could plan your osteotomy at the amount of resection by playing on those two items. At the moment, my surgical tricks intraoperatively are I start by my first cut, distal, behind the insertion of the CFL, not to cut it, and perpendicular to the pitch angle, to the plantar aspect of the calcaneus. My second cut is more proximal, proximal, and is oblique, and the amount of is about 8 millimeter, but is empiric. And I agree that it's reproducible, because if you say, I do this, I do that, and I remove 8 millimeter, but why 8 and why not 9 and why not 6? So I think it could be interesting to make a study to calculate, because now I prove that the overlegs of the calcaneus was one of the main causes of the pain and one of the main causes of impingement. It could be interesting to perform a study to plan this according to these two kind of items, the pitch and the length. And probably some people you have to remove 6, some people you have to remove 9. Could be interesting. So if you want to do this work, I could help you. No more question?
Perhaps Mr. Siddiqui would like to talk.
Yeah, sure.
Mr. Siddiqui?
Yeah.
Hello.
Yeah.
Can you hear me?
Yeah, sure.
Yes. Thank you very much. No, I thank you for this wonderful opportunity to listen in on your vast amount of experience.
Thank you.
I don't have much experience of ZADEX osteotomy. I have done arthroscopic and open calcaneoplasties.
Yeah.
My only problem with doing Achilles tendon surgery and calcaneal osteotomy is creating a big soft tissue flap and causing wound complications. I have tried midline posterior approach, tendon splitting, and digastric approach. I've also tried the lateral approach to the Achilles tendon insertion. My only concern is when you combine osteotomy and the Achilles tendon, sometimes the flap causes problems with the wound.
Okay, so my advice is first, two separate approach. Okay, one for the Zadek and the calcaneoplasty, a lateral approach,
Yes.
and a medial approach, medial to the Achilles tendon, for what you want on the Achilles tendon, resection of calcification, FHL transfer, and so on. When you do a Zadek, when you do a lateral approach, do not dissect the subcutaneous tissue, straight to the bone. If you are enough posteriorly, that means if you have enough posteriorly to the way, to the road of the cerebral nerve, there is no risk to damage the nerve, right? So
Yes.
no subcutaneous dissection, so there is no problem with the skin. I never had, except on 2 cases, because it was a patient with arthritic and so on, but at the end it was solved. I have no problems of skin necrosis. I have 2 healing, a little bit complicated, but at the end it was healed because of the condition of the patient, the status, the medical status of the patient. But if you operate patient without no subcutaneous dissection, there is no risk to have. The second one, the Zadek osteotomy, is a calcaneus osteotomy. That means the risk of non-union is very few, is very low, because the calcaneus is a very good bone. And when you do a medial approach, if you are strict medial to the road of the Achilles tendon, the skin is very far from the approach on the lateral aspect. So there is no problem on that aspect too. So for me, the skin is not the problem in those operations if you respect some rules.
Yes, thank
And
you.
so be confident with that.
Merci.
No worries. How are you, Mr. Borgi?
Fine, and you?
Fine. So any question or remarks or additional comments or whatever? So maybe if there is no more question, we could close the debate. Or if you want, if somebody wants to add something, it's now to do it, because after that I'm going to leave downstairs, because we are locked down already. So I hope you enjoy this webinar. I hope you will join me for the next one. The next one is about the flat foot, the flexible flat foot. So some tricks again about the different transfer and so on. I try to organize also DPC for the French surgeon, DPC on ankle instability. That means DPC on site. That means with surgical demonstration in my theater. But for now, everything is stopped, and I don't know when we could be possible to restart this, but it could be an option also. And I will continue the webinars on the with InVivox and so on. And you have also the webinars from EFAS, and there is a 1 monthly webinar from EFAS. And so I recommend also to attend this because it's nice too. So we start last 2 weeks ago with the instability and arthritis, and the second one will be on the ankle fracture and the debate of instability on the ankle fracture and so on. So it will be interesting. Maybe it's in 1 week or 2 weeks. So give a look on the EFAS website, or maybe you receive the newsletter from EFAS. So I recommend also to attend the InVivox webinar, because there is a range of interesting topics. So I thank you, my moderator, Mr. Antoine Vidal, and thank you to attend also from a day off, because today it was a day off, but I think since many weeks there is a lot of day off, so that doesn't change me, but probably for you not. So thank you very much for your attendance. I wish you a nice weekend, And bye-bye. See you in the future.
Bye.
Thank you very much.
Bye.
Bye.
Et au revoir.
Thank you. Bye-bye.
Thank you.
Thank you, everybody. Bye-bye.
Bye.